While SARS has disappeared from the world stage, MERS, which is the Middle Eastern Respiratory Syndrome, has emerged to take its place as a coronavirus of concern. It is a viral respiratory illness, much as SARS was. But this one was first reported in the Saudi Arabian Peninsula in 2012, most likely acquired from animal sources, and in particular, camels are considered to be the most important reservoir that would affect transmission to humans. All cases have so far been linked to travel in or near the Arabian Peninsula. As of July 2016, there were nearly 1,800 laboratory-confirmed cases and 634 deaths. In May of 2014, there were actually 2 persons in the U.S. who tested positive for the disease, but no subsequent transmission resulting from that. The signs and symptoms of MERS are quite similar to those of SARS, and they start with nonspecific flu-like complaints, including fever, cough, shortness of breath, sometimes diarrhea, nausea, or vomiting. They may proceed to have complications from pneumonia and or kidney failure as the disease progresses. The incubation period, the time from exposure to virus to when symptoms develop, is between 2 to 14 days, but typically around 5 to 6 days. Transmission, not surprisingly, is through contact with respiratory secretions. The key questions to ask if someone is suspecting a case of MERS is whether one has traveled in the last 14 days to the Arabian Peninsula or a neighboring country. What are those neighboring countries of importance where MERS might be suspect? They include Bahrain, Iraq, Iran, Israel, the West Bank and Gaza, Jordan, Kuwait, Lebanon, Oman, Qatar, Saudi Arabia itself, Syria, the United Arab Emirates, the 2 largest cities there being Abu Dhabi and Dubai, and Yemen. Fortunately, MERS does not appear to be as readily transmitted from person to person as was SARS, requiring a higher degree of personal or close contact. The risk areas for MERS are shown on this map, again focusing on Saudi Arabia itself and the Persian Gulf region, but also extending towards the Mediterranean. An important outbreak outside of the Middle East that occurred first started in May of 2015 when an individual who had traveled to Bahrain, the Kingdom of Saudi Arabia, and the United Arab Emirates returned home to Korea and became the index case for MERS. As a result of various exposures occurring in a number of different hospitals, initially 3, but rapidly becoming several more. There were 135 cases and 35 deaths. It's the largest transmission cluster reported to date. Over 3,000 persons were quarantined and 700 schools were closed as a result. This particular outbreak, like the one in Toronto, highlighted again the need for early identification of cases, for isolation of persons who are infected, for cohorting of those who have disease, the use of appropriate infection control procedures, the need to prevent exposure in the hospital through use of appropriate personal protective equipment, and the need to reduce exposure, particularly in crowded treatment conditions, in congested spaces, the need to control visitor access to patients, and again, the need for respiratory protection, in particular, to prevent transmission. These situations of individuals who are potentially exposing others in crowded conditions in hospital waiting rooms, for example, are not unique to South Korea or Toronto. These conditions occur in the U.S., and if we were to experience any cases here, those situations would need to be addressed very quickly. How does one deal with MERS? There are infection control procedures involving minimization of exposure, the use of standard plus contact plus droplet plus airborne precautions. These individuals may indeed develop either a large droplet or small droplets that might be infectious over a wide range of distances. And it's important to have appropriate caution especially during procedures that will generate aerosols. As for SARS, the treatment of MERS is supportive only. There's no antiviral drug that we can give, and that there's no available vaccine or post-exposure prophylaxis at the present time. So looking at our novel coronaviruses, again for SARS, a respiratory illness that develops acutely with appreciable mortality. It's transmitted in healthcare settings very well prior to the implementation of appropriate infection control procedures. The impact on healthcare workers is disproportionately large, as shown by several outbreaks. There's a major impact of aerosol-producing procedures like intubation and suctioning, and induction of sputum and the like. And there's high importance attached to proper donning and doffing, that is, placing on and removal of personal protective equipment. The need to do that in the right sequence, both in using the equipment and removing the equipment, and hopefully in all cases when possible having trained observers to assist with the appropriate sequence and process. We know that we can interrupt transmission through implementation of appropriate infection control procedures if they're done early, and the lessons from SARS hopefully should mitigate the impact of any future MERS cases that might occur here or elsewhere around the world. So again, my thanks to Dr. Isikoff from the Department of Emergency Medicine at Emory.